has been that insulin, when it is chronically elevated, starts to drive most of the chronic diseases that we're all afraid of. And I say chronic disease, and of course I mean that, and that's certainly what I focused on in the book. But in hindsight, I wish I would have had a chapter about infectious diseases, as the world's so interested in that lately. And disorders of insulin are really the leading pre-existing conditions that predict whether someone will have a very serious or very mild reaction to a viral infection, including the one that we're all aware of at the moment with COVID. So that's the lab goal, and my personal goal is, and I guess I could sum up in a way that it's to help encourage the awareness of insulin in any discussion of chronic diseases. So insulin resistance is really two things, and I have to describe these two pillars, or rather these two sides of the coin that we call insulin resistance, in order to truly understand why it's connected, or rather how it's connected to almost every chronic disease. Now, insulin resistance itself is a term that was originally created to describe what is seen in an isolated cell culture, we call it. Like, imagine the kind of typical little petri dish of cells growing in a little incubator in a lab somewhere, like what I have across the hallway in my lab right now. What we could do with fat cells or muscle cells or liver cells, we could put chemicals on those cells and then spike them with insulin and then see what the insulin does. And we would detect, insulin isn't doing what it used to do as well as it did before. That is insulin resistance. So the actual term insulin resistance really reflects this one phenomenon that some cells in the body, not all, and we need to keep that in mind when I describe the other aspect, the other half of insulin resistance, but some cells of the body don't respond to insulin as well as they did before. So, and importantly, every cell in the body literally has insulin receptors. In other words, every cell in the body is going to respond to insulin in some way, or rather, insulin, if I flip it, can stimulate every cell in the body to do something. So some of those cells stop responding as well to insulin. That's the insulin resistance aspect of it. But we can't tease out the other aspect of it, which is chronically elevated insulin. If you have insulin resistance in the body, so now we're leaving the individual cells and we're going to the whole body. If you have insulin resistance in a clinical situation, for example, then you have hyperinsulinemia, or in other words, elevated insulin. And that's important because remember, some cells continue to respond to insulin as well as they ever did. But now, unfortunately, swimming in this sea of insulin, they're overstimulated. They're hyperactive with regards to what insulin would be telling that cell, what it would be telling that cell to do. That is insulin resistance. And then your follow-up question of why it matters, it's because almost every chronic disease in some way, to some degree, is going to be either caused by this confluence of these two things that I'm calling insulin resistance, or it's going to be made worse or exacerbated by insulin resistance. And this covers an enormous spectrum of disorders, which was certainly part of the reason I wanted to write the book. But things as seemingly distinct, you'd hear these disorders and you would think they have nothing in common. Things like Alzheimer's disease, migraines, fatty liver disease, infertility like polycystic ovarian syndrome in women, or erectile dysfunction in men, hypertension, osteoarthritis, and more, much more. You'd hear that list and think those are not related to each other at all. And yet, to a very large degree, in some instances completely, insulin resistance is the common root. I could imagine someone who would hear this discussion at some point in the future, and they would think through their day, and they open their medicine cabinet, and you have this guy who's taking a medication for his type 2 diabetes. He's taking a medication for his blood pressure. He's taking a medication for his erectile dysfunction. And what he could do is realize, wait, these medications are just trying to trim these branches coming off of this sick tree. And so rather than just focus on pruning these little branches that are always going to grow back, because a medication will never solve these problems, you just cut down the tree. You acknowledge the common root here. And so when you acknowledge the role of insulin resistance as being fundamental to so many of these diseases, and they really are, I would encourage anyone who reads the book, please look at all the citations that I reference in the book to know that I'm not just pulling this out of thin air, but you acknowledge the role of insulin resistance as a common cause. And then once you do that, you acknowledge the role of lifestyle as a solution to the insulin resistance, because it is at its core a lifestyle problem. And the food we eat, as I like to say, is the culprit or the cure. And so we just have to shift it. If the food has been the culprit, let's change the way we eat and let it start working for us rather than against us. And when I hear of, say, a physician who's started to change because they've sort of been converted, they've seen the light, it is like they have a renewed enthusiasm for their career. I have a very good friend here in Utah who had been practicing medicine for over 20 years and just getting a little discouraged with what he thought in his more honest moments was his inability to actually heal people, especially those that would come in with type 2 diabetes. Yep. And, they'd leave with a prescription for Metformin, and then eventually they would graduate to insulin therapy and more and more. And the only follow-up visits with these individuals would be increasing the dose of the medication. But the problem with that paradigm is, for example, type 2 diabetes, it is not caused by a lack of Metformin. A lack of Metformin is not the cause of this disease. So giving the drug, whatever the disease, isn't going to cure the problem. You have to take that more fundamental view, which is the drug will only treat a symptom. What's the cause? How can I address it? And so this friend of mine, Steve Barry, he's sort of flipped that switch and has, like I said, just a renewed enthusiasm. He is healing people, and that's a bit of a cliche word, but type 2 diabetes is classically looked at, which is fundamentally an insulin resistance problem. It's viewed as an irreversible problem. And yet what happens when a person comes back a few months later and there's zero clinical evidence of the disease? Well, that to me sounds like you've cured it. That is absolutely true. Insulin does definitely, it most certainly affects glucose. It's one of the most powerful signals to lower blood glucose. And thank heavens we have it. The absence of insulin is lethal, partly because the person would have chronically vastly elevated glucose levels, and that is dangerous. And it can lead to a coma and death, not even over that long of a period of time. So you eat a starchy, sugary meal, glucose levels will spike up. And if it stays too high for too long, that's unhealthy and even lethal. And so insulin shoots up out of the pancreas into the blood, opening these glucose doors, if you will, in a handful of tissues throughout the body, but most especially the muscle, that allows the glucose to come out of the blood into the tissues. And then insulin, having done that job, comes back down. That's typically the only job people believe insulin has. And of course, that's very, very far from the truth. Insulin actually only stimulates glucose uptake into a very few tissues: fat cells, muscle cells, the heart, and to some degree, the brain. At every other cell in the body, literally every other cell that responds to insulin, doesn't have anything to do with glucose uptake. The theme of insulin throughout the body at every cell is, perhaps I could say that it tells cells what to do with energy. And to get a little more specific, it will tell cells what to do with nutrients, with the kind of base building blocks of nutrients, glucose, amino acids, and fatty acids, and then tell the cell what to do with those things. Not that it necessarily will stimulate the uptake, although to various degrees it does. It does drive, in some instances, the movement of those nutrients from the blood into the cell. But even in tissues where it doesn't stimulate the uptake, it still tells the cells what to do. Like, for example, the liver. The liver does not need insulin for glucose uptake. The glucose can just come rushing into the liver on its own. It does not need insulin as a mediator. But nevertheless, When insulin is high, as glucose is high, it tells the liver what to do with that glucose, namely to store it as glycogen. It tells the liver what to do with the fat that it just took in, with the amino acids that it just took in. So again, the theme of insulin is to tell a cell what to do with energy. And then we start to see this reflected to varying degrees across certain pathologies. Like with Alzheimer's disease, as the brain has become insulin resistant, it now cannot get enough glucose to meet its energetic needs. And as the blood vessels become insulin resistant, now they don't get this signal to produce nitric oxide. And so they don't dilate as well, and they stay constricted, causing that being one of the main causes of hypertension. And then other diseases have nothing to do with the kind of anabolic effect of insulin, but more of just highlighting the variety of insulin's effects. Like, for example, the theca cells of the ovaries. The theca cells have a very unique job. Those are the steroid-producing cells of a woman's ovaries. And the theca cells have an enzyme in them called aromatase. And aromatase will mediate the conversion of testosterone into the estrogens. Of course, you know, estrogen is a sort of small little family of hormones itself. But aromatase mediates that conversion. All of the estrogens were once testosterone, and aromatase just converts them. And of course, ovaries do that more than testes do in a man, which is why a woman will have relatively higher estrogens. Insulin inhibits that enzyme, oddly enough. And when insulin is chronically elevated, like with insulin resistance, it inhibits aromatase too much. And now this woman's ovaries are producing too few estrogens to the point that she no longer ovulates, and too much androgens to the point that she now has maybe more coarse body hair like you typically see in a man. So all of this is just simply reflective of the myriad and variety of effects that insulin initiates throughout the body. And indeed, there are truly dozens of other examples I could go into, and in fact do at book length.